Good afternoon and welcome, dear doctors. Sanofi has been at the forefront of diabetes management for nearly a century. Looking to the future, we are building on this proud heritage by pioneering new possibilities for people living with chronic diseases. As part of our commitment to innovation to improve quality of life and in supporting the sustainability of our healthcare systems, Sanofi welcomes you all to the PSEDM Annual Convention 2021 Symposium. New perspectives on the 100-year journey of insulin, glycemic variability, and time in range. To formally welcome you all, we'd like to call on Sanofi's Diabetes Medical Manager, Dr. DJ Villeza.
Good afternoon, doctors. First, I would like to thank the PSEDM for this partnership and congratulate on the success of their annual convention. We welcome our attendees to our lunch symposium today as part of our commitment to support the continuing medical education of our doctors. Today is going to be an exciting lecture on the legacy of insulin therapy entitled New Perspectives on the 100-Year Journey of Insulin, Glycemic Variability, and Time in Range from our esteemed speaker, Dr. Elizabeth Pacheco. Thank you for your time and hope you all enjoy.
Thank you, Dr. DJ Villeza. It is an honor to introduce our speaker for this afternoon. She is a professor at the University of the Philippines College of Medicine, Division of Endocrinology and Metabolism. She's also the past president of the Philippine Society of Endocrinology, Diabetes and Metabolism. She is an endocrinologist at the Medical City and the editor-in-chief of the Journal of the ASEAN Federation of Endocrine Societies. Please welcome Dr. Elizabeth Paz-Pacheco.
Thank you for your kind introduction. Good afternoon, everyone. As we celebrate the 100th year of the discovery of insulin, allow me to bring you back in time to its early beginnings and subsequently fast forward to our current issues relating to glycemic variability and time in range. Indeed, the discovery of insulin is life-saving. Insulin was purified from the animal pancreas, and this injection was given to this young boy, Leonard Thompson, whose photograph is illustrated here for you, before and years after that important insulin injection. You can see how robust and truly alive this young boy has become after many years of insulin injection. So clearly, the discovery of insulin was a medical miracle. Let us go into a sentimental journey of the discovery of insulin, looking at its timelines. It started, of course, with Banting's idea, a collaboration with MacLeod, the beginning of the experiments with the medical student Charles Best, the activity of the crude extracts that were looked at after the dog was pancreatectomized. Subsequently, this purified extract became available to be used in humans. The results were published, the patent was applied for, and the manufacturing for mass production was put together by a variety of pharmaceutical companies. It's very interesting and sentimental to look at a historical note here from Banting's notebook, which I will read. Diabetes, ligate pancreatic duct of the dog, keep the dogs alive until the acini degenerate, leaving the islets, and try to isolate internal secretion of these to relieve the glycosuria. Interesting indeed, right? Because at that time, urine glucose was the way of measuring diabetes. And in fact, this was really looking at isolating insulin from the islets of the pancreas. During that time, there were a variety of clinicians around the world taking care of children and adolescents with diabetes who were dying before their eyes. And truly, out of Boston, Elliot P. Joslin, the founder of the Joslin Diabetes Center, had this to say in his journal. and I quote, "By Christmas of 1922, I had witnessed so many near resurrections that I realized I was seeing enacted before my very eyes Ezekiel's vision of the valley of dry bones." Yes, the patients were living with the amazing discovery of insulin. That, of course, was catapulted with the great distinction of the Nobel Prize, granted to Frederick Banting and John Macleod, which was eventually shared by Banting with Charles Best and by Macleod with James Collip. The insulin isolation did save lives, but even at that early time, it was evident that there was some level of variability between batches that made it difficult to determine the proper doses to be delivered to patients. Also interesting is the fact that at as early as at this time, there was already a note of an increased risk of hypoglycemia, something that was going to be a side effect or an effect of treatment that we will be seeing through the years. Let's now go over the 100 years of evolution of insulin therapy from its discovery in 1921 to its first use in humans in 1922. There was insulin crystallization in 1926, and in 1946, the first intermediate-acting insulin, NPH insulin, became available, in contrast to the earlier insulin, which had to be given multiple daily injections per day. This allowed for a fewer number of injections to be given to the patients. Subsequently, in the 1980s, was the introduction of the human insulin. In the year 2000 was the first basal insulin analog introduction, which with modern technological advances, of course, have led to second generation basal insulin analogs being produced a few years ago. So fast forward to 2021, where are we now? Diabetes continues to be a growing global epidemic. It is expected that by the year 2045, 629 million of us in the world will have diabetes. And together with that will be increasing staggering mortality rates, diabetes complications that will impair quality of life, and bring about a lot of health expenditure for the individual and national governments alike. So it continues to be a great challenge for all of us as we go into these years, 100 years after the discovery of insulin. We recognize that type 2 diabetes is a progressive disease. You can see here from work out of the UKPDS that even in the early years prior to diagnosis, in fact, there is already an initial loss of beta cell function. Here demonstrated by looking at beta cell function by HOMA beta, that pancreatic function has already declined to the level about 50%, even before the patients are diagnosed. In another study by Ralph DeFronzo, looking at both lean and obese individuals, the same story has been demonstrated here, showing to us that as patients convert from normal to pre-diabetes to frank diabetes that we are able to diagnose, there is a dramatic decline in beta cell function over a period of years or so, where in fact, for most of the patients, at the time of diagnosis, they may have in fact lost about 80% of their beta cell function. So clearly insulin function, ability of secretion, as well as the amounts of insulin present in the individual with diabetes becomes an important part in our understanding the pathophysiology and the pathogenesis of this disease. With that, through the years, we've been using a variety of diabetes, anti-diabetes agents, sulfonylureas, metformin, DPP-4 inhibitors, thiazolidinediones, GLP-1 receptor agonists, and SGLT2 receptor inhibitors, which all have been available in the past several years. And they've been really great and helpful in improving glycemic control via improving insulin secretion and ameliorating insulin resistance. But you can see here that the range of A1C reduction it is able to achieve is anywhere between 0.5% to as much as about 1.5% A1C reduction. In contrast, The use of insulin, which is really replacing the deficient hormone, is able to provide us with a more robust A1C reduction in the order of about 2.5%, as illustrated here. So our guidelines, this is coming from the American Diabetes and the European Study for Diabetes groups, tell us that when patients have an A1C above target despite dual or triple therapy, then you need to be considering injectable therapies. Here illustrated is the use of adding basal insulin in addition to either also having an option of using a GLP-1 receptor agonist. But when you look at these details, indeed, the addition of the basal insulin is in favor for patients who have higher A1C and are clearly symptomatic. The use of basal insulin is important as it is able to lower the risk of hypoglycemia and also lower glycemic variability, which are two of the more important characteristics that we really need to identify when we're choosing an ideal basal insulin. So why basal insulin? We said we wanted to treat fasting hyperglycemia, as that in fact is importantly seen as what's happening in a 24-hour plasma glucose condition. Here is illustrated how individuals have an increase in their fasting plasma glucose, and that continues on through the day and rising even with their excursions postprandially. We do know that this initial data arising from Monnier in France have been reproduced in our Asian populations here from Malaysia on the left and from Korea on the right. You can see that as A1C increases, here shown at 8%, 9%, and greater than 10%, there is an increasing level of fasting hyperglycemia illustrated in purple, as opposed to lower postprandial glucoses seen in light blue. Here illustrating that as patients' A1C rises, you can see that there's an increase in fasting hyperglycemia. Same was seen in the Korean population, and you can therefore also see that the postprandial glucose reductions and excursions were in fact less as the A1Cs were rising. Therefore, in these studies, fasting hyperglycemia was predominant and should therefore be the focus of our therapy. So a balanced approach for insulin therapy is essential for us to carry out, understanding again that when your A1C is rising, you're dealing more with fasting hyperglycemia, not ignoring, of course, the postprandial excursions that we also need to address as we go on in managing these patients. But in terms of doing some sort of a protocol, what will be important, therefore, is to fix the fasting first, because fasting hyperglycemia is a determinant of what will be eventually the postprandial glucose excursion. It also predicts the degree of post-meal hyperglycemia and the magnitude of the post-meal excursion from baseline. Here you can see is a clinical trial comparing insulin glargine given once a day in comparison with insulin degludec aspart in a co-formulation. And as you can see here, this is the baseline, the dotted lines, and week 52 in the full lines. You can see that at the 52-week period, the treatments showed similar mean 9-point SMPG profiles throughout the meals. And in fact, if you look at fasting glucose, there was lower pre-breakfast or fasting SMPG values observed with insulin glargine as compared with IDEG aspart. So indeed, lowering FPG using glargine as monotherapy is effective in lowering this 9-point SMPG. So here is where we try to put everything in perspective, providing a balance between timely, effective, and stable glycemic control on one end, improving your A1C targets, preventing complications, and lowering your healthcare utilization, and using regimens that are less restrictive, more flexible, and improving adherence and quality of life. On the other end of the scale is, of course, the patient's fear for hypoglycemia, which often becomes a barrier for their more intensive control. We want to be able to allow for optimal dose titration, improving glycemic control, adherence, and reducing morbidity and healthcare resource utilization. So where are we now in terms of measuring blood sugars? What are our glycemic metrics? And are there newer metrics that we need to be considering? Again, along the line of insulin discovery are the years of blood glucose monitoring technology development in time. So the very first use of home SMBG was in fact in the 70s. Subsequently, the continuous glucose monitoring in 1999 was developed, and this was further standardized with CGM reporting about 5 years or so ago. So in 2013, there's more use and utility globally of the CGM. And this allows us to better understand the concept of time in range, which is something that we all need to be familiar with as we now try to continue our management of both hyperglycemia and reducing hypoglycemia in our patients. So we've been using A1C for the longest time, right? Maybe over 20 years or so with the DCCT, subsequently with the UKPDS. We know how to handle A1C. It's relatively easy to measure, and the standardization has been improved over the years. It's not really very cheap, but it's still relatively cheap looking at some of the newer technologies. But we were very familiar with its utility in terms of looking at data that predicted vascular complications. And often with all of this important data, we're able to make our management decisions. On the other hand, though, A1C is not perfect. It is, in fact, a poor indicator of variability. You get some sort of an average. That average doesn't really tell you if there are peaks or troughs, and where a lot of this lowering low blood sugars and high blood sugars really have an impact on outcomes. Also, there's a potential of confounding by certain conditions such as renal disease. And of course, in the end, it really just gives you some sort of a 3-month average measure of glycemia. So there's really a need for metrics beyond A1C to help us address these limitations. So here is how the CGM works. You have here on the left the so-called glucose range targets that we want to achieve for our patients, which is to get them into a target range between 70 to 180 milligrams per deciliter in about 70% or more of the time. We want them to be in the hypoglycemia range of less than 70 in about only 4% of the time, 54 less than 54 milligrams per deciliter, only less than 1% of the time, or the least number of time they are in the hypoglycemia range is of course the best. And also not to get them greater than 5% of the time in the range of blood sugars that is greater than 250 milligrams per deciliter. That is really critical and important as we want to achieve these goals for our patients. And on the right is an example of a patient who can have a measurement of such time in range using your CGM. Here, the individual target range that we wanted is only achieving less than 50% of the time. In fact, 40% or more of the time, the sugars are high, and about 10% of the time, the blood sugars are low or very low. So this is a tool that will help us be able to get these numbers into the range as we've seen here in the targets, and get us a better sense of really what's happening through the day for our patients with diabetes. We want more of the green, and we in fact want less of red that are our barriers to management. So we're used with A1C, and how does the time in range correlate with A1C? There are studies that have looked at the comparison, and an extrapolation of that is shown for you here. When the time in range is about 70%, that approximates an A1C of about 7%. When the time in range is about 50%, that's about 8% of an A1C. So the dictum here is for a 10% change in your time in range, That is equivalent to about a 0.5% change in your A1C, up or down, wherever the patient range is actually falling under. So this also allows us to have an understanding of how the time in range fits into all of the data we've learned through the years as we were using that for A1C. So indeed, the uptake of CGM has been rising globally in recent years due to these improvements in technology. TIR is more likely to capture these fluctuations in glucose levels and will therefore help us understand the impact of acute interventions. And TIR adds value as an outcome measure. I did tell you that a lot of our studies in the earlier years used A1C, but now emerging data have shown us that indeed we can also look at it from the perspective of TIR. Here, shown for you, hazard ratio of developing retinopathy was increased by 64% for each 10% lower TIR. And that was also seen for microalbuminuria. It was in fact increased, the hazard ratio of 40% for each 10% lower TIR. So if you're not able to achieve your TIR, then you now can be able to show the occurrence of certain complications. Here demonstrated are retinopathy and microalbuminuria. Here again are a few more examples of how the CGM profiles are useful. You can see here in one patient over 12 a.m. to the next 12 a.m. period, a 24-hour period, where even if you look at a average glycemic measure somewhere here, you're not recognizing the lows and the very high that is seen within a 24-hour period. And that is something that is really important for us as physicians and our patients to recognize. You're extending that to a 2-week period. You will see now a better perspective of how your patient's blood sugars are going. Encircled here in red are the points where maybe the patient wasn't recognizing, but here are clearly shown in the CGM time points where the blood sugars are dropping. And therefore, this could be addressed as you discuss all of these events with your patients and be able to improve their glycemic control. Now, the interest with basal insulins have to do with the formulation of second generation basal insulin analogs. And here, looking at insulin glargine U100 and the second generation insulin glargine U300, you can see that in green, insulin glargine 300 provides a smoother profile in comparison to blue, which is your insulin glargine U100. It has been demonstrated in the morning injection here. Very similarly, also a smoother profile with insulin glargine U300 in the evening. And here also looking at comparisons between morning and evening injections with the use of insulin glargine U100 and U300. So clearly, the improvement technologically with the second generation basal insulins have provided this lower degree of variability. The other area has to do with hypoglycemia, and we've been recognizing that clearly. Why are we afraid of severe hypoglycemia? Because clearly there is an increased risk of adverse clinical outcome in terms of major micro and macrovascular events, cardiovascular disease, non-cardiovascular disease, as well as mortality. Indeed, hypoglycemia is important to recognize, to prevent, and to do a lot of efforts in terms of reducing, because that really translates to adverse clinical outcomes and even mortality. So here is illustrated for you, insulin glargine U300 use showing a reduction in hypoglycemia compared to U100 insulin glargine. A variety of studies, clinical trials have looked at this and have demonstrated that indeed the U300 insulin glargine does provide a reduction in hypoglycemia in all of these patients nocturnally on this particular panel and any time of the day in the other panel. So we can say that the more modern and second generation basal insulins are really providing us with this benefit. So we go back to this scale that we wanted to put together and really have as our perspective when we're managing patients. On the one hand, effective glycemic control, and on the other, preventing the risk of hypoglycemia. I do believe the basal insulin second generation formulations have provided us with improvements in providing and all of these outcomes as we've desired for our patients. And so with that, I'd like to end with the following key messages. Indeed, after 100 years of insulin discovery, insulin remains to be the single most effective glucose-lowering drug, and is something that's really very important, life-saving for many of our diabetic patients. We wish and hope and pray that all of our patients who need them are able to be able to get their insulin, and not be limited by cost and other constraints. Secondly, our principle as we address hyperglycemia with progressive disease is that we want to fix the fasting first, and that has been shown by the data I've described for you, as well as the impact of lowering fasting hyperglycemia, also providing lower postprandial glucose excursion subsequently. A1C has remained to be an important parameter for us in measuring glycemic control. And we do know a lot of data arising from data that used A1C, but we have to understand the availability of newer technologies. And I've introduced to you the use of CGMs, which are going to be able to provide for us an understanding of the so-called concept of time in range and glycemic variability. And all of this can complement each other as we continue to manage our patients and address their concerns. And of course, also considering some of the financial constraints for these technologies. Finally, insulins with the low glycemic variability and longer time in range truly help us by reducing morbidity and adverse clinical outcomes in our patients. And with that, I thank you everyone for your attention.
Thank you, Dr. Pacheco. We now proceed with the open forum. But before that, doctors, please welcome our moderator. She's a member of the Board of Trustees for the Philippine Society of Endocrinology, Diabetes, and Metabolism, and a training officer for the section of endocrinology, the metabolism at the Chinese General Hospital and Medical Center. She's also a consultant for St. Luke's Medical Center, Quezon City, and a fellow for the Philippine College of Physicians and for the Philippine Society of Endocrinology, Diabetes, and Metabolism. To join Dr. Pacheco, please welcome Dr. Laura May Tan Tin Hai.